Okay, Dr. Kasky, you want to get started?
Yes, hello and welcome. We are excited to have you all join us today for the Adolescent Health Mini Conference. I'm Dr. Rachel Kasky, joined by Dr. Tamitra Latimer, and we are here to facilitate the conference this morning. Next slide, please. We have some important adolescent health resources, some of which I'm sure you're very familiar with, but as a reminder, the Bright Futures, which is a national resource available to pediatricians and those that take care of children, as well as the Illinois chapter of the AAP Adolescent Health Toolkit, both of which can be found online. The website is there, but certainly easy to find via Google search as well. Next slide. You can see the disclosures here for all of our presenters. Nobody had any relevant financial disclosures today, which is important. Next slide. There is credit available. At the end of the morning, you'll have information on how to take the necessary survey and get your up to 3.75 Category 1 credits. As mentioned, I'm Dr. Rachel Kasky at University of Illinois, Chicago, joined by my friend and colleague, Dr. Tamitra Latimer from Ann and Robert H. Lurie Children's Hospital. And we are thrilled to be here today, facilitating the discussion, introducing the speakers, and then we'll be moderating the session at the end as well. As I mentioned, there will be an evaluation at the end, so we'll give you that information at the very end. To get CME credit, we will need everyone to complete an evaluation within 7 days of this webinar. Everyone has been muted. All the attendees are muted. So during any of the presentations, as well as during the session at the end, if you have any questions, comments, or thoughts, please go ahead and use the question box, the Q&A box that you can see. And as you probably saw when you logged on, today's session is recorded and will be available as a longitudinal LMS platform on the ICAP website if you or others would like to rewatch any of today's sessions. Our first speaker is Dr. Maria Ramander, Medical Director, Substance Use and Prevention Program. She is also at Ann and Robert H. Lurie Children's Hospital, specializing in adolescent and young adult medicine. She's an associate professor of pediatrics and will be speaking today on best practices for adolescent care and patient confidentiality. Thank you so much for joining us this morning.
Thanks for having me. Oh, sorry.
We also have Dr. Felicia Scott Wellington, Chief of Section of Adolescent Medicine, Co-Director of the Department of Pediatrics DEI Task Force at the University of Illinois, Chicago. She will be the second speaker, titled Empowering Adolescent Patients to Take Ownership of Their Health and Healthcare. And finally, we have Prag Shah, hospitalist pediatrician at Ann and Robert H. Lurie Children's Hospital, as well as Angela Berger, LCSW, also at Lurie Children's, talking about supporting the transition from pediatric to adult health care. Slide. Can we get the next slide?
Sorry, it's lagging for a second. 1 minute.
We'll just need to get this into speaker mode. Dr. Ramander, thank you for joining, and we'll let you take it away. These are beautiful slides.
Thanks, guys. Looking forward to a discussion around adolescent confidentiality, and knowing that everybody comes from different places and may use different EHR systems. And, I think we can kind of work together to talk about what's possible where we are, and what we can advocate for in our own spaces to help protect confidentiality. So yeah, I'm Mariah Ramondar. I use she, her pronouns, and am have been part with Tommy of this group where we were meeting weekly. Sometimes it seemed like more than that, to really get confidentiality protections for youth within Lurie. When and had been doing this to lead up of the 21st Century Cures Act going into action. And we have also been part of the American Academy of Pediatrics reports and guidance on protecting confidentiality in EHRs. So next slide. And so by the end of this session, I hope you all will be able to articulate the types of care minors can consent to in Illinois, identify information blocking exceptions, and determine areas in which providers can leverage their EHR to protect confidentiality, along with areas for advocacy and improvement. Next slide. So when we're able to protect confidentiality within care, youth are more likely to access care, answer honestly, and come back to see us. So this is, confidential care for adolescents is recommended by major medical associations, but we also recognize that family involvement can be beneficial when the youth is open to it. And so as much as we can, include family in certain aspects, that can still be really important to quality care. Next slide. And so in Illinois, minors can consent to contraception services, STI testing and treatment for 12 and above, substance use treatment for 12 and above, and that includes medications, mental health therapy. It does not include medications, so need parental consent for that. But, youth can access a certain number of therapy sessions before parental consent is required. And then also minors can consent to prenatal care, adoption, abortion, and care of their child. Next slide. Some ideas for maintaining confidentiality and establishing that within your practice would be sending out, posting confidentiality policies, so that, some practices might send this out as people, youth are like about to reach, adolescence. And so that parents kind of get that warning that things, may change a little bit. And, but also an opportunity for youth to practice talking to doctors on their own or providers on their own, and developing their independence and learning how to take care of themselves. It's also, we have some little, simplified posters in our office spaces that kind of, talk about confidential care and privacy. And then discussing that confidentiality policy with parents and teens at the visit, while mentioning the limits of confidentiality, which can be, safety concerns and potentially billing. Asking parents to step out and promising to invite them back, which I think I rarely have pushback from parents, and do this at every visit. When you're like, well, have you come back in to talk about the plan? People tend to be okay with that. Not everybody. And then having private time at each visit so that teens don't have to ask for it, might come in under, their parent might be their ride to get them there because like, oh, their stomach's been hurting, but what they really want to talk to you is something that they want to talk to you privately about. And they know that that will happen. So, that can be helpful. And then periodically reminding the teen about confidentiality, especially when you're getting to the really, sensitive parts of your discussion. Okay, next slide. Oh, and then breaking confidentiality is more of an art than a science. It's not black and white. Some things may be clearer than others, but, it's really kind of down to the individual situation and relies on your clinical judgment. And so, the goal of breaking confidentiality would be preventing imminent harm to the patient or others. protecting the patient's health and safety. And the more recent the activity, the more imminent the need would be to discuss with somebody else. And some things that can be helpful when you need to break confidentiality are, reminding the patient, first of all, remember when I said that when we talk private, most of what we talk about can stay private unless I'm worried about your safety. Now this is the thing that made me worried about your safety. And then, why it's necessary, what details. And I think this can be a nice opportunity to maintain rapport with teens, in being able for them to negotiate what, details they would like to keep private. Like maybe they don't want to, out their friend who did the thing with them. And that's not the, important part. The important part is maintaining that, patient safety potentially. So you might be able to honor that. And so you might want to, kind of telling what details you think are important and seeing if there's anything the teen is like, that makes me really nervous and why. Who is going to disclose? That would be, is it going to be the teen would like you to talk to the parent with them in the room, with them not in the room? They want to tell their parent first with you swooping in afterwards to check in on, hey, what was shared? How's that going? And then, focusing on how disclosure is going to help, connect to care or what the next steps are going to be. And, when you're talking to the teen alone, and especially in front of the parent, emphasizing the patient's positive attributes, appreciating their honesty, their willingness to change. There's possibility that they've already started making changes and they're like, oh, I'm never going to do that again, and kind of saying, what are these positive aspects of this interaction? And then, highlighting any acceptance of further evaluation or treatment. Next slide, please. And so here are a couple obstacles to confidentiality that can be areas that you might need to explore with your patients. Where you want to keep things confidential, but these may be areas that it might be broken. And so that's with explanation of benefits, particularly for people with private insurance. Folks with Medicaid in Illinois don't necessarily get set an explanation of benefits. So that kind of makes it a little bit easier for us in maintaining confidentiality for those patients. In the pharmacy, filling prescriptions, refilling, calling in, reminding that a prescription's there, kind of navigating that system. Reminder calls from clinic, who are those going to if a patient might be seeing you and their parents don't know they have that appointment. Patient portals, and we'll talk a bit about how we are able to protect some confidentiality there, but that's, that's the tricky part now that, where proxies and parents can see within the portals, accessing appointments and other care. So, if this is something where the teen's like, my parents cannot know any of this, and you're like, okay, well, how are you going to get back here? How are you going to get there? How are you going to access all of these things if if your guardians can't be involved? Errors. So we're all human, and if all of the things we have to do to protect confidentiality require our brains and our fingers to change things within the EHR, there's definitely opportunities for us to make mistakes. And then health information exchanges where they're when you're sharing notes with other writers, or they can see, that in an ideal world, they would maintain the confidentiality that has already, been established within your clinic. But once the information is out of your hands, it's out of your control. Okay. And great. Next slide. Okay, so just wanted to go over a couple examples of or areas where we are allowed to be exempt from the prohibition of information blocking. So the Cures Act, really the goal of this is to improve, information sharing between patients and providers, or providers and patients really. And so they only allow you to block information in a couple ways. And so that would be preventing harm, privacy, and then a couple others. And so we'll focus on these top three because that's really kind of where providers can interact with the system and participate in this. So next slide. Okay, so the preventing harm exception was initially just preventing physical harm. And then the Office of the National Coordinator of Health Information Technology did clarify and expand this to include emotional and psychological harm. Next slide. And privacy exception is where we are allowed to block information from being transmitted in areas where a minor is legally allowed to consent to that care, or based on the wishes of the individual. And now I think we're probably more protected in teens is if they're allowed to protect that information legally, or it's going to cause harm. So I think for adolescent care, I usually use privacy exception probably the most with the, for the minor consent. Next slide. And then infeasibility exception it speaks to where an EHR has not developed the means to unambiguously segment information that you are allowed to block more than just the minimal necessary. But then that gets in the way of this information sharing. So, that's not fully in the spirit. So the more we can be granular about what we're withholding and what we're sharing, I think that is probably best and most in line with the Cures Act and just, patient knowledge. And then uncontrollable events, this includes, disasters and emergencies. So, next slide. Okay, so walk through some cases and examples of things that we have within our Lurie Epic EHR. Okay, next slide. Okay, so you have a 16-year-old who's coming to establish care. Next slide. And so while checking in, you have this awesome administrative team at the front who's really invested in taking care of adolescents and maintaining confidentiality and getting everybody signed up for, our portal is called MyChart. But they provide information on the patient portal. They help the teens sign up. They give, automatically just give the parent basic access. In our portal, we have we have a couple different, but for teens, basic for parents where that, ideally it's kind of limited access where, hopefully it would not break confidentiality. They can't see certain things like labs and things like that. But teens can consent to let their parents have expanded access. And then use the front desk sends sensitive questionnaires to the teen account and parent questionnaires to the proxy account. And they are sitting in the waiting room, filling those out on their phones. So next slide. So this fairly recent paper in pediatrics has some recommendations for how to engage different parts of, a practice in getting people connected with patient portals. And so this, kind of who does what within your practice will, can certainly vary. But these are some ideas. And so, from a health system and clinical provider standpoint, it's important to have policies for access to adolescents' health information so everybody's on the same page. And then from a registration or triage staff, with the patient alone or with the patient and parent together, but they might inform them about policies for access to adolescent health information, explain the patient portal and parents proxy access, and then check that access to see if, the contact information is up to date or that everybody does have access, ensuring the correct patient's contact information. And that we have found, and this has been found, more broadly, is that parents have their teen access very frequently, where they have signed up as the patient, but it is the parent. And then proxy access, asking the patient alone about their desires to have allow their parent to access their chart. So, and your front desk staff, in some offices, maybe they're like, feel comfortable talking about the patient alone. That might be something more that, the medical assistant, nurse, provider might be doing. Okay, next slide. And clinical providers, so in addition, can kind of do all that other stuff, but can explain more about the 21st Century Cures Act and information sharing, blocking exceptions with the patient and parent together. Next slide. And then with the patient alone, can have that more in-depth conversation. And when you're having like private time and a patient's, nervous about, I'm telling you this, where is this going? You can kind of describe what, protections you have access to within the EHR. Like, when I'm talking to a patient, I'm like, and they're telling me something, they're like, I really don't want my parent to. I'm like, okay, I'm putting this within a confidential note. We can, block this order from being seen. I'll get your cell phone number, kind of, and I can walk through how we can try our best to maintain confidentiality, and then what the limits are, depending on your location and the realities of life. Next slide. Okay, so when you are talking alone with the patient, next slide. And, within our EHR, we are able to segment into a confidential note because, a lot of visits are not completely confidential. Like the parent is aware that they are there or even like with them. So like the whole note doesn't necessarily need to be unshared from the patient portal, but a portion of it can. So this is what our confidential note looks like. And, that notice up top is so that if this is transmitted or, other people are reading, they know like, okay, this was provided in confidence. And then that blue text disappears, and that just reminds people what was legally allowed to be within this confidential note and blocked. So next slide. And so the patient reports sexual activity. And so then you're gonna talk more about some other things, and we'll show you some ways that we handle that within our system. Next slide. Okay, so in managing, we have we determined certain ICD-10 codes to be sensitive. So we have diagnoses, excuse me, that and problems that are blocked automatically from the patient portal. And so, but then for orders, we manually have to block them. They're not automatic, which, in a lot of cases, families know, you got a teenager who has cramps and is taking birth control for that. Like that doesn't need to be blocked. Like parents should know they're getting their refills. They're keeping an eye on that. And that actually, if the teen isn't, sexually active and using it for pregnancy protection, then it can't be blocked. It shouldn't be. So we, can click hide from proxies for some orders. We can manually release them. And so where we can see the result and determine if we are going to send it to the portal or not. And so, for pelvic ultrasound, that might be helpful in case, just might discover things that you didn't know were going to come. So great. Next slide. Okay, and then we have the ability to print a proxy view after visit summary, and so that those I was showing you kind of those areas that are not transmitted automatically to the portal, but then if so if the parent went in there, that's what they would see, and so if we're going to print out an after visit summary, we want to make sure that those parts are also not included and break confidentiality in that way. Next slide. And so now we've got another patient who's a 19-year-old who has a history of ALL and wants to discuss birth control. And her parents are still super involved in her care. Next slide. Okay, and you get a pregnancy test, but forget to change it to manual release, and because you're human, and then it comes back positive, and you panic. And before, you're like, okay, got to study myself before I, check in on how this patient is doing and, see if they know about this. But first thing, let me just make sure that their parent isn't just notified that there's a new result in their MyChart account. And so you pop in and check their access. And so this is my childhood AOL username here. And you see that my dad has adult access. So he could totally see that positive pregnancy test. Okay, so we are going to next slide. We could revoke that if we check with the patient and we can say, hey, do you actually want your dad to have access to your chart still now that you're 19? We could revoke that and let, the medical records know. But, we still want him to have access. Patient still wants him. So we're going to retract that. So we can either prevent the automatic release if it hasn't been released. All of our labs are like, release at a certain time, so there's a little bit of a lag. So you have some time between, where you might actually be able to review results before a patient sees them, because the Cures Act does allow a little bit of some time before it's released, or you could retract it from MyChart or the portal. Okay, next slide. Okay. And then there certainly are more other areas where we can protect information. We're still kind of working on confidential visits where a whole visit is kind of confidential and so that you can't see that appointment's even made, and all the documentation and orders and everything within it are not shared to the portal. And then we do have confidential departments, like our substance use treatment program is within a confidential department because there's, higher federal regulations that require more segmentation of information from general medical records. And so and of course, there's trickiness when things are automatically blocked because my patients can't see that they have an upcoming appointment in the portal because it's even blocked from them. So, it's all imperfect. And so, when you're looking at information from other places, and just knowing that, what's transmitted may not be complete and what you're transmitting to other places, may be missing information. And to try to do, ideally, we'd all do our best to protect the confidential information that's shared with us through information exchanges, but we can't always promise that once it leaves our hands. So next slide. And so our recent this month, I guess, um, policy statement and I think it's a technical report on confidentiality has some recommendations, and I'll focus on just two areas. And so these are just some recommendations that I'll leave you with. And so these are for the pediatrician and patient relationship, that we should respect adolescent and young adult requests for confidentiality when legally required or permitted, prioritize health and well-being, which means that sometimes that might necessitate breaking confidentiality. Encouraging minors to share important information with their parents and including them where we can, supporting adolescents and young adults and parents' understanding of development, so autonomy and decision making, and having that consistent alone time. Promoting alignment with parents centered on well-being of adolescents, knowing that we're all kind of coming from the same places, that we want this person to be healthy, and probably maybe even the parents, more than us, love their kid and want them to be healthy. But so exploring where there may be cultural or religious perspectives that are informing, their decisions. And remaining aware that individuals who experience racism, discrimination, marginalization may be particularly concerned about ensuring confidentiality and where this information is going. Important for us to be familiar with state and federal laws, including those that apply to young adults covered as dependents. So, which is so wonderful that so many youth can stay on their parents' insurance till 26. But then, at least in our state, their parents get to know about everything that they're paying for. So we need to do some more advocacy around that. Next slide. And here are some recommendations for practice management. So advocating for treatment, payment, and operation practices that support confidentiality, developing practice policies and operations that protect confidentiality, and developing and providing patients and parents with a notice of privacy practices, which we're required to by HIPAA, but, kind of thinking about ways to make them developmentally appropriate so that the patient can also, read this not just for the parent, that, health literacy levels are taken into account, language proficiency, and making sure that these notices are specific to, where you're practicing. Next slide. And here is some information for patients from healthychildren.org. And so information for teens, what you need to know about your privacy. It's a nice little web page or handout. And next slide. All right.
Thank you. That was an excellent talk. We do have some questions in the chat that I'll just go ahead and read. First question, is substance use a reason to worry about patient safety and need to share with parents, excuse me?
Yeah, it really depends. I'd say not all substance use is like an imminent safety concern. And so I think that if you disclose all activity that a teen does, then you have not established any areas of confidentiality. So, some example, and again, this is gray. So you've got somebody who's overdosed multiple times is continuing to use. Okay. So maybe that's a time where you're going to engage the parents. I think anytime you are really concerned about imminent harm, death, mixing substances, driving while intoxicated. And, you may not need to share all of the substances. You might just, they may not need to know all the details of all the substances used, but, what are the important things for maintaining their safety? Is it like, we got to talk to your mom to make sure that you are not taking the car out when you go out with your friends and that there's like you have an Uber account set up, or what is it? How are we going to negotiate that? So I think like where you can discuss together, and you can always ask the team, what do your parents know? Because they might know more than you think.
Yeah.
Or what do you think your parents know? And the parents might know more. So I think kind of coming up from a place of like what is shared, what is known, and what do I think is missing, but really important. But it doesn't have to be everything.
I think that's great advice. And I'm struck how many times you ask a teen what their parents know, and they're like, oh, everything. And
Right. And
like,
then you don't have to
oh,
do all, right? It's so much
yeah,
easier. And you're like,
exactly.
wonderful. You're so like,
Yeah,
I love that relationship. I still think
right.
we have this private time because, you know,
Or
uh,
the parents found out already, even if it
yeah,
wasn't them.
right.
Yeah,
Uh-huh,
yeah,
right. Yeah. And
that's
that's why
right.
you're dragged here today. Yeah.
Second question regarding mental health treatment. Can teens receive mental health medications such as SSRIs or other without parent consent?
Not in Illinois. You do need parental consent to prescribe mental health medications. Substance use medications, you're protected. But mental health medications, you do need consent. So, and that can be tricky to navigate that conversation sometimes, and I think I have a lot of patients where they think that their parent would not be cool with it, but I'm like, can I bring it up with them, and say this came from me? And then, not that I'm here to force anybody to take anything they don't want or do something they're not comfortable with, but then I've had, so many times where like the parent was like, oh my gosh, I've been so worried about them. Thanks for bringing this up, but then you still certainly do have those times where parents are not on board. And so just exploring, what their concerns are and like, okay, then can we get into therapy? Let's give that a shot. I'm going to check back in with you. Let's talk some more. So, okay. Ooh, they're flowing in now.
They're flowing in. Do all EMR systems have the ability to separate info for adolescents versus parents? Basically, the confidentiality protections you reviewed.
They should, right? Like, I
I
mean,
think so too. Yeah,
yeah,
it's a
they
great
should.
question.
But so a problem, a huge problem with the 21st Century Cures Act is that it required providers, health systems to start sharing information before they required
Yeah,
EHRs to develop the systems to do this. So no, I have heard of places where, they just block everything for everybody over 12. Okay. So that's one way to do it. And then on the flip side, I had places where, we have pediatricians working at adult hospitals where they just don't think about us and they just shared everything. And
right, right.
it's really you gotta like, unfortunately this takes advocacy and I wanted to share some specifics about what we can do with an Epic because I think we worked really hard and I think our system is certainly not perfect, but it's pretty good. Like I think we have the ability to protect a lot of things. And so knowing what's possible, because you can push back and be like, they say you can't do it. Yes, you can. Like you figure it out. Not you as the provider, but like your information system should be able to support this.
I think it's a good reminder that people ask, right? Find out what the rules are at at your institution, your medical center, and just kind of be an advocate, like you said, because if there are areas for improvement, nobody will be thinking about it unless you do. So this isn't something the IT folks are thinking about.
Yeah, it's unfortunate. I know it's a heavy lift. I know that's a lot to think about on top of like seeing patients, all just taking care of patients, and then have to do this too. It's a lot.
Canteen consent to HPV vaccine if parent does not.
Mm-hmm. So now this is, I believe in Illinois, we are
We
protected
can. Yeah.
in doing that.
Yeah.
However, I would proceed with caution. Okay.
Yeah.
So I think that this, just because I think you are protected, doesn't mean that you will be, like that, you might not have some, but I think that this is a hot, that vaccines, unfortunately, um, though backed by science, and this is one of the best ones we've got. It's super effective and amazing. But, I think I would encourage as much as you can in all areas, trying to get like, a parental buy-in on things. And when I have a patient even who like wants birth control and they're like, my parent will kick me out of the house if they ever find out. I'm still worried about going forward. I'm like, how can we get people on the same page? Because though I am totally protected in doing this and not worried about my license or things like that, I don't want negative consequences to come. So as much as we can like collaborate. So yes, you can, but uh, yeah, careful. Other thoughts from the other our leaders here, Tommy.
Yeah, I think that is very challenging, and it is not one that I'm willing to push back on. Because here's why. Yes, the Illinois does say that we can administer this vaccine, but if the parent finds out, and they will, if they have access to my chart, they can look to see what vaccines were given. What does that do to the relationship? Because yes, you are trying to forge a relationship with the adolescent, but what about with the parent? You still want, can you all hear me? Okay, yeah. So you still want to be able to have a relationship with both. I mean, we're pediatricians. That's one of the reasons why I chose this field is because it allows me to form relationships with both the parent, the adolescent, the child. And so I am very reluctant to push and give the HPV vaccine if the parent is like, no way, don't want it. I just don't think that it's something I want to pick up and put on my mantle to that might potentially destroy that relationship.
Also found that when parents are really opposed to it, it is rare a teen is going to push to get a vaccine themselves until they're older. Young adults, it's a different story. And I've had a lot of late teens or late 20s ask for it. And at which point, of course, they're consenting for their own care. So it's irrelevant. But it's pretty rare that a, 13-year-old is like, oh, my parent doesn't want it, but go ahead and, put a needle in my deltoid. So
yeah, it's one of those rare situations where, when I'm talking to teens about like sexual health and stuff, we're having that conversation often privately before, and the parent hasn't already said they may not have this. But like with vaccines, you have just had a parent be like, no. And then you're like, let's do
yeah,
this in secret.
that's
It's
so true.
it's just different. Yeah.
At what
And
age can oh, I'm sorry.
Sorry,
Go ahead.
I was going to say, you do bring up a good point, Dr. Caskey, about, when revisiting this, when they are able to consent at 18, right? As maybe that's, and we're having Dr. Shaw talk about transition, but maybe as they're leaving, maybe that's an opportunity to revisit it and
Exactly.
administer it.
And one of our audience members did comment that they've provided the vaccine to a teen without parental consent who was sexually active as STI protection, which again, as we said, is technically protected, but acknowledges this rarely happens. One last question for you. At what age can we see teens without a parent or adult?
Yeah, I mean, it can for the things that they can consent to on their without parental consent, you can see them without. I have patients who access our clinic. We have like an annual consent to treatment that like parents sign. And so if a teen gets to my appointment on their own and it's like for a mental health appointment, and I'm like, I still need to include your parents, they've already consented that they can see me, but I'm like, I get them on the phone, so I try to like, facilitate knowing that like parents are busy, teens are busy, they often have different schedules. If they can access me, like I still try to, include parents on the phone, messages, things like that, make sure that they consent to the things that parents need to, and also keep them in the loop about their care.
I think we've gotten through all the questions.